as arthroplasty surgeon. I've been doing this thing for the last 8 years right now. I remember in 2013, when I came over here, I was so interested in teaching everybody. By the way, today, in this day, I'm proud to tell you that I have 5 people from Al Faisal University, male and female orthopedic surgeons. Can you hear me far away or not? So, first of all, anybody interested in orthopedic surgery? 1, 2, 3. Okay, thank you. So, the thing is right now, what are we going to be talking about today? Britain, upper extremity. What's an upper extremity?
Upper limb, shoulder.
Upper limb. Upper limb starts with what?
Well, it starts with shoulder.
Shoulder. What's in the shoulder?
Bones.
What are the bones?
Scapula.
Thank you. Scapula. After that, humerus, radius ulna,
And then the carpals.
and
Carpals and phalanges.
thank you. Okay. What are the joints in the upper extremity?
We have the clavicle.
Shoulder joint.
But you said something very correct. What is it?
Yeah, the supraclavicular joint or the scapular
أيوة،
humerus.
أيوة، أيوة، حطوا. هات شيء. What is it?
The bone socket.
It's a bone. You're mixing up. We have the AC joint,
Yeah,
okay?
acromioclavicular,
Acromioclavicular joint.
yeah.
We have the shoulder joint. We have the elbow joint. We have the wrist joint and the phalanges. Okay, those. It's a ball and socket. This is a hinge joint. Okay, and this is as well as a hinge joint. So we're going to be talking today about something very familiar and very well known. Shoulder, elbow. Sadly, with the boys, okay, I was unable to finish this lecture because of. Anyways, okay, I was not able to finish shoulder only. So they did not have the elbow, so they did not have the wrist and the joint. Okay, so if we are successful, we'll finish this lecture nicely. We're going to be talking about the rotator cuff, we're going to be talking about the shoulder instability, and we're going to be talking about the joints as well. This is the anatomy that you have to understand it and you have to know it very well. We have over here, this is the clavicle, the coracoid, the acromion. This is the coracoid process. This is the coracoacromial ligament and the coracoclavicular ligament. The blue one is the most important one, is the bursa. Okay, this is the bursa that you have. It's called the pillow between the bone and the soft tissue. This is the biceps tendon. You can see it over here. Why do we say biceps?
Because it attaches to the biceps muscle.
Okay, what are they? من وين لوين? A long head of biceps starts from where and ends
From
where?
above the humerus. Above the humerus. يعني فوق الhumerus to the scapula. اللي هو the
وين بالسكابيولا؟
um,
It's in the picture.
Between the
Where? Wait. There's a name. This is your level. This is what I want you to learn. I'm not going to ask you to come and operate on my patient. Okay? I want you to know anatomy. Long head of biceps start from the glenoid, superior part of the glenoid process. The glenoid. What's the glenoid? You know what's the glenoid?
yeah, it's the
Okay? It's the upper part of the glenoid. شايف الصورة? And the short head of the biceps, where does it come from?
humerus it's on the shaft.
No. إلا؟ أعتذر منك صراحة. No, it's not إلا. Okay. No, it's not written in this picture, but I'm going to show you another picture. What is this? Coracoid process. The long head is from the glenoid. The short head. That's why it's a long head and a short head. واحد فوق واحد تحت. The coracoid process is the origin of the short head of the biceps. You can see this is the rotator cuff muscles. What are they? كم واحدة؟ كم rotator cuff فيها؟ What are they؟ هذه أخرى. برافو عليكم. Excellent. طيب, okay. This is another picture that shows you, okay, the impingement. What's an impingement? It's a painful abduction from 60 to 20 degrees and a repetitive friction, micro hemorrhage. Whenever you have مثلا trauma, injury, what's going to happen to your tendons? Swollen in the tendon. What's going to happen? لما الوتر هذا كبر الوتر صار حجم الوتر كده. S, what happened to? Everybody speaks Arabic هنا ولا
range
أنا؟
no English. No. Range of motion. No everyone. Not everyone speaks.
Okay, I'm just asking. That's why I'm asking. So I will avoid speaking Arabic. Okay. There will be swelling in the tendon. Whenever there is swelling in the tendon, there will be impingement. That means the tendon will not be moving freely. That's what we call impingement syndrome. Okay, impingement is swelling of the tendon because of the tendonitis that's happening in the tendon. And this is what we see over here. This is the most common rupture tear in the muscle and the tendons of the shoulder. Is that which tendon is this one? Supraspinatus. The supraspinatus tendon is the most common tendon rupture. Whenever we have it ruptured, what's going to happen?
Pain.
What is the function of the supraspinatus?
The هذا more than 25 fixation. وزيادة على الدلتويد. So the first one is the deltoid and then the
Lateral rotation.
Initiation of the abduction. Okay. So whenever you have a supraspinatus tear, what does the patient do? He bend his shoulder and then he lift it up. Because of the supraspinatus tendon tear. How do you diagnose it? How do you get? Patient come with pain, restriction range of movement, and tenderness. What's a tenderness? This is the same word that I told it to the boys. Okay, it's not touch. We don't touch in as a doctor. We palpate. Pain with palpation, not with touch. So this is just don't say I touch the patient. If you say to touch the patient, it has another different meaning. Okay, we are not touching patient. We are palpating the patient. Okay. Then okay, special test for each tendon. We're gonna talk about it later on, and it's mostly diagnosed with MRI. Why?
Tissue characterization.
Thank you. MRI is made for soft tissue, while the X-ray is made for bone, not hard bone. T soft bone. Okay. It's for bone. What's a conservative management?
Relieving the symptoms.
What's a conservative? Non-surgical. We have conservative and surgical. Conservative, what are you doing? You are dealing with your, what do you call it? Relieving the pain by painkillers, okay? Avoiding certain movement. He doesn't have tear, he has just tendonitis, swollen tendons, injections, restricted range of movement, avoid above head activity. This is what we call conservative management. This is how it goes and this is how it's gonna be happening. And usually it is done for whom? Okay. I have two patients, 25-year-old female, and I have a 65-year-old female. The 25-year-old female has a supraspinatus tendon tear, and the 65-year-old female has a supraspinatus tendon tear. Whom do you operate on? I will operate on both. I will operate on both, honestly. Why? For two reasons. Reason number one, if the you have to ask life of style. If the patient has an active life of style, if the patient is 65-year-old, and if you're 25 years old, who's on her phone 24 hours and not doing anything. You have 65-year-old female who's cooking, acting, doing everything. صح ولا لا؟ صح. 100%. Okay? I know that you're recording, by the way. Okay? But this is how it goes. Okay? But the thing is, right now, the 65-year-old, she wants to go back to her normal life. If she's active, she's thin, good tendon activity, I will operate on her. The sooner, the better. What if you delay surgery? What will happen? The tendon. Now, thank you. What will happen to the muscle? لا. It will be shrunken. When the tendon when the muscle is shrunken and it goes back in, it's going to be hard to pull it back up. So that's why the sooner that we operate, the better. أي سؤال بالروتيتر cuff? Any question you want to ask about the rotator cuff, guys? You got it? Understand it? This is the basic. I'm not going to go deep in it, okay? I want you to understand the basic. تفضلي.
So we only prefer the conservative when the patient has like a sedentary lifestyle?
لا. Conservative management depends on the type of the tear. It's a small partial tear, not affecting his daily life. Give it some time, it might heal. Okay? If the tear, wallah, it's really huge and the tendon is shrunken back in, listen, you're not gonna regain it, you're gonna keep on having pain, your bone is exposed, I have to pull your tendon, put it back. This is the time that you have to, and you have to explain. Usually it's elderly patients that come with you, not young people. How many patients, or how many person of you guys had a shoulder dislocation? Anybody had a shoulder dislocation? ولا حدا? I can tell that you're not honest, okay? Okay. Shoulder dislocation is the most common injury in the population. Why?
Because it's an easy joint.
Well, no. It's the most difficult to dislocate. Okay. Because you usually do it every time. You're moving your shoulder. How many times you raise up your hand? How many times you eat? You're moving your shoulder every time, okay? طيب. But the shoulder, you're gonna see right now, it's not an easy joint to be dislocated. And it's 1.7 annual rate, okay? It's having higher recurrence rate according to the age. 70 to 95% of persons, if they are younger than 20, and if you have a 16, 17, 18 with a shoulder dislocation, I'm gonna advise him to go for surgery directly to avoid recurrence dislocation. From 20 to 30 years old, then the patient then it's less and less to have dislocated. 15 to 20, the patient, this is above 40, alhamdulillah, I pass it, okay? With no shoulder dislocation, it's very rare to be dislocated. There are several important, this is a very important slide, okay? Ligament in the shoulder. Ligaments are soft tissue structures that connect the bone to bone. You can see in the shoulder, the bone it's a ball and socket, as you mentioned a few seconds ago, and it is not connected directly. These ligaments are the main source of stability for shoulder. They help hold shoulder in place to avoid swelling. What's a labrum?
Extension.
Now?
Is it the one that extends from the joint to
برافو
more
عليكي.
cavitation?
It's like a hump, like زي ما طب, okay, like a hump, okay, that covers from the glenoid. This is the glenoid process. This is the labrum, the circumferential. It's like what in the knee? Thank you. Excellent. Great. Okay. The meniscus is the shock absorber. This is the that prevent the dislocation of the shoulder. So the labrum is the most essential part in the shoulder to avoid dislocation. Now, this is when you say it's an easy to be dislocated. Look at those tendons. رب العالمين حاططنا في shoulder. It's really tough to be dislocated. Okay? You have the subscapularis, you have the supraspinatus. It's surrounded by everybody, okay? But the force that happens that causes dislocation. انت في عندك الليبرم, في عندك الكبسول, وفي عندك المسلز. So 3 layers before it gets dislocated. How does it dislocate?
Downward.
Mechanism of action. What is the mechanism of action?
Down, out. Like downward, outward.
لا, this is for reduction. Okay? abduction. Let's have term. Abduction, external rotation. You are planning to throw something, it went out. Okay? ليش؟ لأنه the thing that you have in your hand, you're throwing it, the force you're doing it, it's gonna, your shoulder is gonna pop out. Okay? Whenever it pops out, why does it come out? Either you have extra force, okay, or injury from the posterior part of the shoulder that hold to happen, or okay, you have a hyperlaxity syndrome, which is more common in female, okay, because of the estrogen and the progesterone, and that can cause this problem. What is the most common dislocation, anterior or posterior?
Anterior. Oh, inferior is the most common.
عليكي. I'm really proud of you. ما شاء الله عليكي. This is really good. I love you. What's your name, بعزة? Sama. Okay, great. Okay, but it doesn't have an anterior, inferior alone. It has subluxation. When it goes down, this is subluxation. It's not dislocation. Dislocation when it goes anterior, inferior. Anterior, this is the dislocation when the shoulder, the head is completely out. The thing is right now, okay. Anterior or posterior. When the most common shoulder dislocation is anterior. When does it happen posterior? With a medical problem. There's a medical problem that causes posterior shoulder dislocation. يعني المريض عنده مرض. He has certain disease that causes posterior shoulder dislocation and bilateral. لا الوينج سكابيولا شيء ثاني.
Would it be Marfan syndrome?
I'm gonna ask you by the way. Wait for it. Okay.
Would it be Marfan syndrome?
لا مو Marfan. It's something else. It's not Marfan. The people who has convulsions, epilepsy patient. They are a normal patient, normal, special time, jalo convulsions. How do they convulse? They first of all, their hands are this way, they internally rotate, and they start convulsing, and suddenly posterior shoulder dislocation and bilateral. By the way, this question you might be asked today, tomorrow, anytime. Posterior shoulder dislocation bilaterally. With what disease? يحط لك 15 يحط لك Marfan يحط لك شو يحط لك epilepsy. It's epilepsy directly. And remember me when you answer that question. Number 2, other reason for unilateral posterior shoulder dislocation. When does it happen? هذا اوكي بس لا it's not that way. لما تيجي تتفلسف او وحده منكم حابه تتفلسف وتحط يدك في شيء الكهرباء اوكي and you got electrical shock, the first thing what you're going to do, you're going to pull your back hand and posterior shoulder dislocation. So electrical shock and epilepsy, you have to remember those two things. طيب, when the shoulder dislocates, okay, what will happen? You see the small triangle had it before? What is it? The labrum. The labrum, when the labrum moves out, what do we call that lesion? Yes, it's written. Bankart lesion. Bankart lesion, it's the anterior avulsion of the labrum. اللابرم كله بيتحرك لما it's going to go out completely, okay, and it's going to be lax. That's why when you have a younger patient, it's not going to go back easily. So you can operate on them, pull the labrum back, fix the shoulder, and the sooner the better. Otherwise, the current shoulder dislocation. طيب. The shoulder went out, the labrum has moved, and now it's stuck. The head is hitting the glenoid, and there is a groove in the head. What do we call that groove? Hill sac. It's written كمان. Hill sac lesion. Okay, it's you're pulling. The head is dislocated, and then suddenly there is a groove in the head right now, من الglenoid. That's a Hill sac lesion, and the sooner you operate to avoid recurrent dislocation, then the more كل مرة every time it hits, and the Hill sac lesion gets bigger and bigger. So operate soon, avoid Hill sac lesion. Okay. طيب. This is when you see the labrum. As you can see, it has been overstretched. This is what we call the Bankart lesion. And the Hill sac lesion is this groove over here that you see it in the shoulder after reducing it. Most common nerve injury? Axillary nerve. How do you know that he has an axillary nerve injury? Shoulder is dislocated. You cannot move it. Huh? She's saying something. It's a stiff hand. It's something else in the hand. أيوة. إيش اسمها هذه الحركة? When the hand is this way. Drop wrist. Drop wrist. Okay. Drop wrist. It's what he or she has. Okay. When you have a drop wrist, okay, the boys tell me it's a radial. It's not axillary. But the radial, where is it coming from? Thank you. So axillary. When you have a nerve in proximal nerve injury, you're not going to find the injury over here. You're going to have the result over here, because you start by the periphery. I like girls more than boys. We have the drop wrist, but this is the thing that you have to take care of it. This is number one. I had a case, my relative, Ibn Ammi, literally, okay, I was in Dubai, he called me, I dislocated my shoulder. I said, I'm in Dubai, I'm not going to reduce it from Dubai. So he said, go to any clinic, they will reduce it. They said, okay, and khalas, things went away. I came back 2 days after. He came to see me, holding his shoulder this way. 2 days after 2 days. طبعا I told him he's ما شاء الله مترين ونص وضخم مصارع كان هو. He's my bodyguard. حطه عندي فايل. He's waiting for me. Okay, but the thing is right now it's not reduced. They told me it's reduced. I said it's not reduced. So in this situation, 2 days after, you cannot reduce it in the clinic. He's in severe pain, number one, Other than that, he will never trust you. So you have to take him to the OR, sedation, go to sleep, and then reduce the shoulder. And every time, قاعدة, you do X-ray before, you do X-ray after. لا تتفلسف. From my experience, I don't care about your experience. Do X-ray. Thing is not written, not proven. It didn't happen.
What do you mean by
Reduce, that means this is dislocated, I reduce it, I put it back in. We're gonna talk about it right now. طيب. Whenever you have an axillary nerve injury, when does it recover? It's not torn, it's not cut. The tendon, the nerve is still available, but it's injured.
Really?
6 to 7 months, maybe 1 year. So, because he's my cousin, and everybody knows, they said Ma'ad injured his nerve. Okay, and he stayed that way for the coming. And I sent him and suddenly, right now he's like a monkey, mashallah. Okay, he's moving his hand, he's completely normal, and his back is normal. So trust in yourself. How do they come? They come with severe pain, feeling of instability, and every time, ask them, is it your first time or not? When they are dislocated, they will not talk. They are in severe pain, but he's gonna direct his hand to his shoulder. He's gonna tell you. When you examine him, you're gonna see the glenoid, the humeral head is under his dress, or when you cut his shirt, the glenoid is really outside. You put your hand at the humerus is outside, and the glenoid, you can feel the glenoid groove, okay, whenever it's dislocated. It's really fun, by the way, when it happens. Okay, and it's more fun when you reduce it.
Doctor?
Now,
now you said that the axillary nerve takes about 1 year to restore.
plus or minus.
Okay. So how did you know that your cousin did not have his, like it was not
Excellent
reduced?
question. What do? You answer me.
Ex-
Like, you're asking a question that you need to know an answer. How do I know that he's gonna recover?
X-ray.
What type of? You have to do more investigation. It's not X-ray. X-ray will never show you the nerve.
Nerve conduction.
Thank you. Who said that? That's great. Nerve conduction study. Excellent. Okay. How do you do the nerve conduction study? MashaAllah. You know everything, mashallah. You do the nerve conduction study. You do the MRI, first of all, for the C-spine. You see the C-spine. You see if there is no nerve injury, you go down. Nerve conduction study. You study the nerve from the C-spine until down. It's full continuity, no interruption of the nerve, okay? It's just a matter of time, it's going to recover. And tell him to shut his mouth and disappear. It's going to come back. You have to be confident of what you're doing. Okay? Something else. How do you examine them? What's an apprehension sign? Apprehension. What's an apprehension? It's an English word. Apprehension.
Maybe you are
Yes. Scared of doing something. I don't want you to touch my shoulder. I don't want you to come near to it. Whenever you're going to touch it, when you do abduction, external rotation, he's going to hold you. He might hit you, Kaman Salah. Don't touch my shoulder. Okay? It's going to dislocate. So you have to, first of all, as a physician, you have to gain the trust of your patient. You have to gain the trust of the people who are you dealing with. Don't overwork them. Don't cause them pain. You are here to relieve their pain, not to cause them pain. Relocation sign, you put the patient supine on the position and you put your hand on your shoulder, tell him it's dislocated, I will reduce it directly. So this is what happened with me. Sulcus sign, when you have, this is for you, when you have subluxation, this inferior subluxation with hyperlaxity, it can happen with anybody. It's not an indication that it's a disease. How to diagnose it? With X-ray. Do X-ray, AP lateral, and you do the axillary view to know if it's an anterior or posterior. Those are the things that I might ask you in the exam. Now this one, is it anterior shoulder dislocation or posterior shoulder dislocation? Why do you say posterior?
because it's an
طيب يلا ماشي. What type of image is this? يلا you. See, bravo عليك. Why do you say it's posterior?
posterior because it's
Thank you. Thank you. Coracoid process. actual coracoid process is anterior. This is the coracoid process. If you're going to make this one I will not understand. Okay? It is the coracoid process. No, this is not the clavicle. This is the supraspinatus. This is the spine of the clavicle, of the spine of the scapula. This is the glenoid. This is the coracoid. Okay, and this is the tip of the acromion. So those are the things that you have to understand. Anatomy, guys. I'm not going to ask you about what's the surgical approach of anterior shoulder. How do you approach it? I'm not going to ask you those things. I'm going to ask you anatomy. I'm going to ask you for your level. Because of the coracoid, this is a posterior shoulder dislocation. What is this lesion? What do we call this lesion? بسكوت مع شوية okay, Bankart lesion. Those are the things. Whatever I'm presenting, whatever I give you, you're going to have in your lecture. Okay. Those are the things that you need to understand. What is this lesion? ايوه هو هذا نفسه بالضبط. حيجيكي the one هذا answer that in the what do we call it? L-sac lesion. Thank you. How to reduce the shoulder? How to reduce the shoulder? Bravo, عليك. If it was posterior. Don't. Why are you digging? I did not ask about the posterior. خلاص how to reduce معناتها anterior. Don't dig. Okay. Anterior shoulder dislocation. Posterior. By the way, if it was posterior, what should you do? Yellow. Answer.
You would pop it. So the way you came up, so if it's anterior, it's anterior to inferior, you would go superior and then backwards. But if it's posterior,
We are complicating life. Okay. If it's a posterior shoulder dislocation, never ever try to reduce it by yourself. It has to be done under general surgery, under general anesthesia. Never. Why? Because if you are thinking that it's an anterior and it's posterior and you are trying to pull and you are rotating, you are going to break the humeral head. Never do it if it's posterior. You have full sedation and then do it. Okay. If it was anterior, what do you see over here?
You pull it down,
Yeah.
but down goes, slides in.
Anyways, never ever do this way. Never ever pull and put your foot this. Why? What will happen?
because you are not moving as much.
La, you are moving and it will be reduced. But what will happen after reduction?
Maybe nerves will be
Thank you. Nerve injury. Nerve injury because the axillary nerve is just next to it over here, and you're putting your foot. You think that you're going to reduce it. لأن أنت عنتر زمانك, okay, and you're pushing it with your full power to your quadriceps, and suddenly, rather than reducing it, you're injuring him more. What do we call this technique? تركت أبو قراء, أبو قراء technique. Don't do it please during this week. So how to reduce it? Traction, counter traction. Bring your shmag, bring your tarhal, bring whatever you want. This is you. This is you, the one who's holding the hand. The other side is your nurse or your colleague. He has to be muscular. He has to be muscular. You, as a physician, you are not pulling. He is pulling, and you are just maintaining the hand. And suddenly, spook, it will go in. Don't do anything. Just give it some time. It will be reduced within less than 2 seconds. Whenever you have it in the field, ask the patient, is it his first or the second time? If it's the first time, okay, try to reduce it with your colleagues. Don't do this jerky movement. Jerky movement is bad. Okay, and then whenever it's reduced, you're gonna fix the hand in internal rotation with an arm sling, ice it, and send him to the clinic for further investigation. Any question, Ms. Alaya? Any question? Okay. Frozen shoulder. What's a frozen shoulder?
Too much fibrous tissue, too much
Thank you. Why?
scar tissue.
It's not an impingement. It's different than impingement. Impingement is between the acromion and what? And the supraspinatus. That's an impingement. Frozen shoulder, it's an impingement, but it's from internally, from something inside. Okay. Why? Why does it happen?
Because of scarring.
Huh? Adhesive capsulitis. What's an adhesive capsulitis?
Is it due to repetitive injuries to the area,
Thank you.
as with football players, American football players.
It's not only American. Right now, أبشرك حبيب Saudi football players كمان they have it and everybody has it. But it usually happens in elderly patient rather than, and it happens with a certain medical disease. What is it?
arthritis.
لا. Arthritis تصبح على خير. تندم مرور. What does it have? Diabetes. Okay. Blood sugar. When you have a high blood sugar, uncontrolled blood sugar, patient usually have like frozen shoulder due to high blood sugar. Adhesive capillary, it's a progressive pain and stiffness resolved spontaneously with 18 months. Histologically similar to Dupuytren's disease. Dupuytren is like the capsule itself got swollen the capsule itself gets swollen and stiff. So this is what it causes pain. And patient 40 to 60 years have history of trauma. If the patient sleeps on his shoulder every day, the same shoulder, the same everything, then he cannot elevate his shoulder. Those are the things you have to think about it. Pain worse at night. It's a حين من النوم. I cannot sleep. It wakes me up from sleep. Why? Because when you're sleeping, you don't control your movement. A stiffness complication, okay. Restriction or range of motion of movement, okay. You have to think of rheumatoid arthritis, osteoarthritis, those things you have to think about. MRI rule out other pathology. Usually it's a clinical diagnosis more than any MRI. Conservative management, okay, that you can do it, okay. Supported pain management, physical therapy, psychological problems. Some people that don't think about it, but this is the thing that you have to think about it every time. That okay, physiotherapy and pain management are the most important. Reassurance that he's going to be fine, and there is a special way that I do it every time, and I'm going to show you a video right now on my phone, not on this one. Okay, how to deal with it. What's an MUA?
Injection at the site of pain.
It's manipulation under anesthesia with injection.
Okay.
Back. Okay.
Is this where you like put the person under anesthesia then rotate their arm?
This is what this one. I don't know if you're gonna be able to see it right now because I forgot to upload it to my lecture. This guy, why am I free to show? Because this is my uncle, Ammi. Okay, that I did it for him. He is a diabetic, uncontrolled, crazy man. Allah yastur alayhi. Okay, but he. So I want you to see. Look at him. Listen. Yummy. Let's do it. Yes. See? This is MUA. You will never forget it right now. Okay, now you want to say, you want to insult MUA. You're going to insult him right now. Okay? Okay, so manipulation under anesthesia. What we're doing for him, we are going to just, he cannot AB duct, he cannot externally rotate. I'm going to fix him under anesthesia. You cannot do it while he's awake. He's going to kill you. Okay, so you're going to put it, it's nice. I'm not kidding. It's really something that you're going to enjoy when you do it. And by the way, patients are going to be very thankful. And they're going to love you after surgery.
This is lateral epicondylitis, right?
Why does it happen? Yalla, and you
We see it with tennis players.
tennis?
No, I want to. Yes.
Okay.
And we see it as an external injury at the elbow, and it could.
Where exactly in the elbow? And you must فتحت على نفسك بوابة الله يعينك. Okay, where is the elbow? Just
Lateral epicondyle.
lateral epicondyle. Which tendon?
هذا over يعني.
طيب, it's yes. You have something? Lamu, you have something? Lateral epicondyle, or we call it the tennis elbow. The tennis elbow, because the tennis players are playing with their backhand most of the time. Okay. So what's the opposite of the tennis elbow?
Median.
The medial, from the medial. What is it? Golfer's elbow. The golfer's play, the golfer's elbow. Usually it's less common than the tennis elbow. The tennis elbow is more common. It's repetitive. microhemorrhagical inflammation, edema, and calcification, tenderness at the all the extensor carpi tendon. Okay, with the when you're moving your hand, okay, all the time. This is your tendons, they are moving all the time. This is when you are writing or when you're doing everything. So this is the most common movement that you have doing. And this is a repetitive inflammation of the tendon insertion at the extensor, at the lateral epicondyle. We call it the tennis elbow, as I told you. And here it's either tear or inflammation at the tendon itself. Whenever we have an inflammation, ايش حيصير؟ Swelling, okay, of the tendon, okay? Okay, how to deal with it? How to deal with it? How to deal with it? How do you, how to deal with it?
Physical therapy.
Okay, what type of physical therapy? Patient is in pain. Yeah, doctor, ترى ده بحكي دكتور I cannot move.
First, pain management first.
How do you deal with pain management? Thank you. You got steroids. Excellent. Okay. How do you give the steroid? What's a steroid? What is this word that every patient is scared of?
Okay.
Cortisone. Wow. What's a steroid? What's a cortisone? It's an anti-inflammatory, guys. Okay? But sadly, our population, when you say steroids, doctor, if you feel it's going to go into the bone, I'm going to have osteoporosis. For God's sake, you are 65, 70 years old, you're asking about this thing. You're telling with pain, okay? Other than that, okay, you are a young man. When you take a steroid, okay, it doesn't mean that you're going to die today. Okay? Doesn't mean you're going to be inflated. I'm going to gain weight. For God's sake, I'm giving it in the tendon or around the tendon. By the way, don't give it in the tendon. Never, ever give it in the tendon. It has a certain technique to give it. Don't give it in the, why? Why not to give it in the tendon?
Not to tear the tendon by mistake.
If you give the steroid in the tendon, it will cause tendon rupture and weakness in the tendon. So you keep surround, this, my hand is the tendon, I go in until I reach the capsule. I don't stick it in the tendon. Okay, you can feel it as a surgeon or something. You feel, you touch the tendon, you back up. Don't inject. There's a certain technique and way how to do it. Don't give it in the tendon. You give it in the capsule around it as an anti-inflammatory. Doesn't mean you took it once. You might take it twice. You may take it 3 times. Okay, but whenever it happens several times, there is a surgical way how to deal with it. أي سؤال بالتندن بالتنس elbow? Okay, we still have 10 minutes. كمان. Wrist. This case, I have it tomorrow or after tomorrow. I have a surgery. I'm going to deal with it after tomorrow. We have 3 things: CTS, carpal tunnel, recurrent synovitis, and synovial ganglia. Who has it in his hand? طبعا حد يقول شيء. Yeah. Who knows a patient that has it in his hand?
The ganglia or
Any one of those 3.
Carpal
Carpal tunnel. What's a carpal tunnel? Compression of the median nerve. Excellent. Okay. What's the nerve supply? How do you diagnose it?
they will have atrophy at the base of the thumb.
Wallahi, I am really proud of you girls. MashaAllah alaikum. You are really good. MashaAllah. Atrophy of the, what is the other name of the carpal tunnel? Secretary syndrome. Okay, thank you. Because the secretary جالسة عم تاخذ أوامرك كل اليوم. Okay, وأنت جالس زي عنتر فوق راسها. Okay, and then she has a carpal tunnel syndrome. And then what's the worst case scenario? That I cause the carpal tunnel for her, I operated on her, and I'm asking her to go back to work. She's not going to have sick leave. Okay. So CTS is it's an entrapment of the median nerve at the wrist, and pain, numbness, weakness in the waist, degenerative clinically by nerve conduction study, diagnosed by the nerve conduction study, the same one that you do it to see the nerve. Yes, you do it as well as for the CTS, and treated by median nerve release. Median nerve release. There are multiple techniques, multiple ways. Okay, I did one last week. Okay, it's a 10-15 minutes. There are 2 different ways. I do it the French way. I do it the new technique, the French way. Before they were opening the hand this way, min hina, lin hina. Okay. Now, me myself, I open it from here only. I do a simple opening from here, and you put your scope inside, and it takes 2 seconds, okay? I don't do any incisions over here. Why? Look at the nerve. This is the nerve over here, okay? What they are doing, they are opening it from here, above the nerve, to visualize the nerve. Personally, I can visualize the nerve from here. And then you bring your scissor, and you go with your scissor, or there's a technique that you put your scope under vision, you can see, zzz, done, 2 minutes. This is how we do it in France. مين جايب المويه دي؟ ايوه
Then it's من
I'm
الفصل.
gonna take it صراحه حط ريال هنا وامشي. Okay. Ducurvan or Monsieur le Ducurvan. Okay. I did my training in France. Okay, so this is Ducurvan. Okay. By the way. Okay, the medical terminology, most of it is from France. Okay. Robe, لما تقول كلمة robe. French, robe. Okay. فكل الأشياء اوكي الصالون في البيت عندكم صالون فكل الكلمات اللي عم تتعاملوا فيها it's mostly French and suddenly you know it and you don't تفضلي.
I was going to talk about the next.
يلا talk تفضلي.
No, basically the two nerves at the base of the thumb.
More nerves.
لا, sorry, the two tendons.
What are they?
I don't know them, بس يعني they're
ليش
going.
تتفلسفي؟
The concept is there يعني.
That is good. It's good.
Yeah, and then they're going to be compressed, so it's because of a repetitive strain. And how do we diagnose it? I think, and I read this, I'm not sure.
تفضلي.
You know, there's the Finkelstein.
برافو عليك. Frankenstein test.
Finkelstein.
That's a German doctor with a French diagnosis. Okay. فعيشي حياتك كله من Europe. Okay. Okay. Now we are in Europe right now. Frankenstein test, you either push the thumb down in with overstretch and the patient's going to severe pain, or hyperextension and you ask that you push his finger and severe pain at this moment. I have a case after tomorrow if anybody wants to ask.
We can attend.
Actually, doctor,
I'm not kidding, Sarah. And I told you, I love Al Faisal University, and I have my niece. She's a student over here, and my daughter is coming next year, inshallah. So this is why. And by the way, I quit Al Faisal last year, and I resigned last year. And I really resigned last year, okay? And they made me come back over here. I came back for my daughter and my niece only. Okay. So treated by anti-inflammatory drugs, by steroids. Sometimes you can give a cortisone injection, and usually I do surgically directly relieve. It's just a small incision, and with local anesthesia, and people can go back to their normal life. A ganglion, it's something that happened. Okay, I need a picture. Yes, this is a ganglion. What's a ganglion? Don't tell me you don't have it. Don't tell me you don't see it.
No, we see it.
You've seen it. How do you treat it? What is it?
You hit it with a book.
هذا التخلف القديم. Okay, don't do that. Okay, you don't do that anymore. We are doctors. You get it with a book هذا. لا تعرفي أول. لا you have أول إيش كان يجيبوا لك ريال هذا وريال كذا شو اسمه؟ في عصفور فوق. يفقعوها. This is how it goes before. No, we don't do it that way. Okay.
excision.
But this is correct, you're not wrong, okay? I'm sorry to say تخلف, it's not تخلف, but this is how it goes. Okay. Now this is again, the ganglion, it's a herniation in the anterior capsule and the synovial fluid comes out. It's a gelatinous part. You know the beauty of it, you give local anesthesia, not bring a book, and then you bring a syringe, a needle, you suck it up. And the most beauty part, that you give it to the patient after the surgery.
Why?
You say, well, what is this?
No, I said why.
No, it's his. It's a man. No, I just get it to see what, because he's asking, they're asking what is it, okay? So it's a gelatinous, okay, friction of the herniation with the synovial fluid and repeat it. It can happen again, it can happen again. So how do you deal with it permanently?
Surgery.
What type of surgery? Thank you. You remove the, let me show you something. This is important, I'll talk about it. You remove it, but don't forget one thing, very important, to close the capsule. If you don't close the capsule, it's gonna happen again. So you remove it completely and close the capsule to avoid recurrence. Trigger finger. What's a trigger finger? بالعربي, what do we call it?
اصبع
ايوه
الفيجر.
النطاط اصبع الرجل.
اصبع ال-
اصبع النطاط. Okay, اصبع النطاط. When you it flips up. Why does it happen? ها؟ لا ايش دخل النيرف؟ It's a tendon. It's a tendon. Trigger finger, it's usually happen over here whenever your tendon or the capsule of the tendon is so much stretched. Inflammation of the tendon, you can see in this area that there's like something hitting and then shtuk, goes out every time because the tendon got swollen and the capsule is stretched. So the tendon cannot move every time. So that's why it feels. How do you deal with it? ما فهمتي. Thank you. معك الحلو. أنا ما فهمت على نفسي أصلاً. Okay. You see the transverse retinaculum, this one? This is available all over, 1, 2, 3, over your finger. And why is it available? To hold your tendon in place. Otherwise, your tendon will be floating all over. Hella, the thing is, because you had an injury, you hit your hand, or you're using your finger a lot, your pen is always hitting this area. You can feel, it's usually in the palm of your hand, over here, this area. You can feel like a knot. Now, touch your hand, you can feel your tendon. You can feel your tendon. Sometimes your tendon gets swollen because of an injury, anything. So whenever, usually when you are bending your hand, it's going under the retinaculum, out, in, out. Now, when your tendon is swollen, it cannot go under the retinaculum, or it goes in and gets stuck. So what you're gonna do inside, you're gonna first of all reduce it, and then do a simple incision, release the retinaculum, and that's it. And then the patient will be able to move his hand. It's a local anesthesia, and people can deal with it nicely. Okay. Added a trigger finger. That's my son. Okay, يلا. بابا فيصل عم يضربني. Okay, fine. The trigger finger happens when the tendon prevented from all extension and fibrous thickening of the nodule or the pulley. We call it a pulley, tendon pulley. Point or fibrous. Okay. Forced extension causes a snap. Yeah. It causes a snap. Okay. And common diabetic and connective tissue disorders ده على فكره بشيء ثاني. اوكي فهلا شو اسمه diabetes. The diabetic people usually have more frozen shoulder as well as the carpal tunnel as well as the recurrence syndrome. Okay. It treated with physical therapy, steroid injection, and surgery. Me personally, I don't do physical therapy. I go for surgical directly. Now it's something. يعني صراحة it's waste of time. Guys, okay, it's a short procedure. Its successful rate is more than 100%, and people can be very, very much happy. هذه it is something very, very, very common. Okay, اللي هي المالت finger. المالت finger that you had ضربت اصبعك او زي في المطبخ دحين you hit your finger. There is no wound, there is no anything, but you cannot extend your finger. This is the mallet finger because it's extensive. This is a high indication of surgery. It's a very nice surgery. Okay. Let me, I will tell you a story about my kids كمان. They were having fun, joking with each other. ففي عندي بنتي ناهد وبنتي لينا. They're the الكبار. Nahid was going to come and join of this place. So she pushed her sister, and her sister tried to prevent herself by going back, and her hand went into the glass table. What happened?
Tendon rupture.
Just simple incision, simple scar. من هنا. Put your hand on your part, okay? At the what do you feel over here?
A tendon.
What tendon is this?
Extensive tendon.
Flexor, which flexor? Flexor carpi ulnaris. Okay. When you bend your hand inside, okay, you can feel it get really. So my wife, I was at work, okay, زي هذا, and she called me. Your daughter fell down, and she sent me a picture. Directly, I went to the local clinic around me, and they said, okay, they're gonna close just the wound and go home. I said, don't move, I'm coming. I cut my lecture, I went directly to the doctor. It was an XYZ doctor with different nationality, I'm gonna talk about it. He was trying to close the wound. I said, did you at least open it? He said, I don't want to disturb her. She's a small girl. I said, you don't want to disturb her? I took the local anesthesia. I gave my daughter a local anesthesia, and the tendon was completely cut. And he was planning to close her tendon. So I stitched her tendon. So this thing you have to take care of it. When you don't see a wound, always, when you have a hand injury, explore, then close. Don't close blindly. يعطيكم العافية. Any question?
Doctor, for example, if you have a shoulder dislocation for the first time, it's better to go for surgical procedures.
لا, you have to reduce it first.
Yeah, induce the.
Reduce it, investigate the lifestyle of the patient. If he or she is high active patient, then you have to do surgery.
Doctor, how does diabetes cause frozen shoulder?
بيصير في عندك adhesive capsulitis. الكبسول itself get thickened.
Why?
Why? Because the diabetes, metabolic rate. When you're using your shoulder, your capsule is not going to be thin. It's going to be really thick, triple layers, okay? And it's going to be closing on your shoulder, okay? But that's why metabolically, okay, the capsule get thickened with diabetes, okay, and causes stiffness in the shoulder. That's why it happens in the tendons, command the fingers. That's why you have to release it or manipulate MUA.